Greetings of the day. I'll be presenting a case on Unicentric Castleman's disease, a masquerader. This is a 28 years unmarried girl with 3 months of amenorrhea, referred for a routine pelvic scan. She was sexually active. However, her urine pregnancy test was negative. No contributing medical history was seen in this lady. We saw on ultrasound, transvaginal ultrasound, we saw well circumscribed, solid, non-homogeneous, predominantly hypoechoic mass, which was seen in the left adnexa, measuring 5 by 7, 7 by 2, and 5.6 centimeters in size. It showed a lobulated outline with a surrounding echogenic rim. No cystic areas or calcification was seen, and no acoustic shadowing was present. No surrounding ascites was seen. On power Doppler, this particular mass showed increased perilesional and central vascularity, and with a color score of 3, and on spectral Doppler, it showed a resistive index of 0.5. Uterus, right ovary, and the left ovary was unremarkable. On ultrasound examination with the power Doppler, we could see multiple tortuous vessels which were observed along the left anterolateral aspect of this particular mass and were seen arising from the external iliac vessels supplying this particular mass. The rest of the abdomen was unremarkable. So we were dealing with a solid paraovarian mass with the differentials of a GIST, pelvic schwannoma, lymphoma, or pelvic metastasis. Tumor markers were absolutely normal. Hemogram, urine was normal. HRCT was also normal. Therefore, the lady underwent an ultrasound-guided FNAC, which yielded a hemorrhagic lesion. MRI was done, which showed isointense. The mass was isointense on T1 and mildly hyperintense on T2, showed restricted diffusion and with a low ADC, suggestive of a mitotic lesion. The same findings which were seen on ultrasound was also appreciated on an MRI. So the differential was given to be as a mitotic lymph nodal mass or a connective tissue tumoral mass. She underwent surgical resection, and this mass was seen below the bifurcation of the left internal and external iliac arteries. It was completely excised along with its capsule with preservation of the surrounding organs. And the histopathology revealed to be a unicentric Castleman's disease, hyaline vascular type. Follow-up of this lady was done. She was sent to a hematological clinic for detailed evaluation, and no systemic involvement was seen. There was a case of a localized unicentric Castleman disease. Hence, no further treatment was offered. So, which is a rare disease of its non-malignant proliferation of lymphofollicular tissue and accounts for 70% of Castleman disease. It presents with minimal symptoms and is usually detected incidentally. It involves one or more lymph nodes which reaches a giant size, mimicking a tumoral process. And the similar was seen in our case. Thank you so much for a very patient hearing.